Thank you for the opportunity to speak. I'm going to address the topic of the difficult gallbladder on the intraoperative cholangiogram contrast side of the debate. My only disclosure is that I am incredibly competitive, and I have been trash-talking Ryan for the last several minutes, and so everybody's been so benign up until this point, but I'm out for blood. ICG is safe and effective. There are many studies that look at the utility of ICG in breast surgery and colorectal surgery and biliary surgery. We understand that it's safe. Fine, I'll give you that much, Ryan. But ICG is not for everyone. Despite what was mentioned earlier, ICG is relatively contraindicated in patients with an iodine allergy or shellfish allergy, and that is not an insignificant amount of people. 30 to 50% of people have an iodine allergy, and therefore ICG should not be used in these indications. It's also relatively contraindicated in patients with uremia, and it is excreted through the hepatobiliary system, and therefore in patients with severe hepatic failure, it should also not be used. Whereas contrast dye is incredibly safe. It's a very rare allergy, about 1 in 750,000 patients. And when that allergy does exist, it is very mild and tends to be more of like a rash-like response. Green is a cool color, I'll give you that much. Ninja Turtles are green, avocados are green. Everybody says the grass is always greener on the other side. But green is not for everybody. If you're looking at this screen and you don't know that there are numbers in the middle, you might be colorblind. There are, as of 2021, this is the average general surgeons or active general surgeons in the United States. There are about 25,000 surgeons. About 77.4% of those are male and about 22.6% of those female. And so that leaves about 1,563 surgeons who are not able to use ICG because red-green colorblindness is the most prevalent form of colorblindness. Therefore, ICG is useless for them. There are a lot, and not to mention that black and white is just classic. Oreos are black and white. Classic films were in black and white. Panda bears, who everybody loves, are in black and white. And then, of course, Michael Jackson and very cool Snickers and black and white cookies. With ICG, yes, you can visualize some anatomy. Here you can visualize a cystic duct, you can visualize the common bile duct in the liver. It has been demonstrated to be relatively non-inferior, but with extrahepatic bile ducts, and there might not be a huge difference in sensitivity or specificity between ICG and intraoperative cholangiogram. But the timing of ICG is absolutely critical. So if you see the liver is what's mostly lit up in this, in these two images, particularly on the right. So it's useless for you if you're not able to actually, if the timing is not perfected and you're not able to visualize the cystic duct and the common bile duct. The timing of ICG administration is also super controversial. So some recommendations are to administer the ICG within 30 minutes, some 2 hours. Some meta-analyses range anywhere from 2 hours all the way to 24 hours, which in an elective gallbladder is not reasonable to have a patient come in 24 hours in advance just for ICG administration. It's not logistically feasible to be performed. The argument for having a more delayed time period is to allow for better delineation between the hepatic and the biliary anatomy. And if your timing is not okay and your ICG is not appropriate, if you don't see the whole picture, you may miss some important details. Here's some of the things that you can miss. So to the right, you see a small common bile duct stone at the bottom in a patient with normal labs. This could have possibly been missed if you're just using ICG. On the left, you have intrahepatic biliary anatomy demonstrating a stricture. You could also have intrahepatic stones that would not be visualized with ICG. ICG does take more setup, I'll give you that. But there's always a but. Most hospitals already have an intraoperative cholangiogram setup because that's what we've been doing for quite some time. And ICG is more specialized. It requires a specific kind of laparoscopic tower, camera, and light source. Out of Stryker-specific towers, only about 23% of Stryker-specific towers in hospitals currently have ICG access. At Duke University, which is supposed to be a well-funded institution, I don't have ICG access on our laparoscopic towers at our satellite locations. And once you're set up for IOC, Once you are able to identify that you have a common bile duct stone, you can also intervene. So you can pass a choledocoscope, you can identify and remove the stone, and then you should follow up with a completion cholangiogram. So if you're already there, you're already set up, you're already in the ducts, that you can do the complete process. Whereas if you notice something on ICG, you would still have to ultimately set up an intraoperative cholangiogram to identify the patency of the ducts. What about cost? Fine. The upfront cost is more with ICG. After the upfront costs and the setup, the routine costs are fairly comparable between ICG and contrast. ICG does provide real-time visualization until your student or your resident or whoever gets into the gallbladder, and then there's ICG everywhere. So your visualization is for naught. It looks really cool, but it's very useless. So IOC does require some radiation exposure, but usually when you're wearing lead, about 90% of that radiation exposure is attenuated. And eliminating the use of C-arms would put our rad techs out of work. This is Sarah. Sarah has 2 kids and a goldfish that she would really like to be able to support, and she'll be unable to do so if we only use ICG. So IOC is the tried and true way to go, and black and white does make everything look better. Adorable. Thank you for your time.